you go. And do you want to use the lectern?
I'll use that, yeah.
I'll
People
let
can
you,
see.
I'm on there as well, but I don't need
Okay.
to be, so I'll let you do your presentation.
Okay.
Okay, thanks.
Well, hi everyone. It's really good to be here today and talk to you about the ID Liver project. So I've been working on ID Liver for the last 3 years or so. It started back in 2020 in the middle of the pandemic, so it was a difficult time. But really the aim of the project is to diagnose liver disease at much earlier stages when we can actually make a difference. It's reversible damage and people don't end up in secondary care. So just to give you some background to start with, well, what is the problem? To put it really bluntly, the current pathway for liver disease just does not work. It's inadequate. We're picking up liver disease far too late. Around 3/4 of people in Greater Manchester have a late diagnosis when as I said, it isn't possible to reverse any damage to the liver. It's therefore unsurprising that liver disease is the third cause of premature death in the UK. There's also just too much of it. Approximately a third of the population in Greater Manchester have risk factors for liver disease, and this is simply too many people for the current system to identify, assess, and prognosticate people to the appropriate care pathways in a timely fashion. In addition, it's too expensive. Because the majority of people are diagnosed at a really late stage, this means that people can have lengthy hospital admissions and expensive investigations as well. Liver disease also affects many people of working age, so of course this has an impact on the economy as well. The way the system's set up also means that many people have to travel long distances to travel to hospital for an assessment. It's not surprising that this puts many people off from attending their appointments. And finally, there's just simply too many unknowns. From a public perspective, we found that there's really poor awareness around liver disease risk and what actually causes liver disease. There's often a stigma around it that it's purely alcohol-related disease, but we know obviously that that's not the case. So something needs to be done there to address that. There's also unknowns from a clinical perspective as well, because we've got lots of tests that are available that can say who has liver disease, it can detect liver disease, but there's no test that can actually say who's going to progress to advanced disease, who's going to end up in secondary care, or who is going to have no problems and can just be referred back to their GP and assessed every 3 years or so. So that's the background really about why we need to do something. This slide is just from the Lancet Commission report on liver disease. And I think it's a really important slide because it shows some of the biggest killers in the UK going back to 1970, looking at mortality rates. And you can clearly see that the majority of these, well, all of these diseases, apart from liver disease, have actually been reducing in mortality rates. So obviously this is as we would expect with improving healthcare, improving technologies. So liver disease clearly isn't following that trend. So why isn't it following the trend? Clearly something needs to be done to address that. So why Manchester? What tools do we have in Manchester to begin to address this? Well, I've separated it between the bad reasons and the good reasons, but it's not necessarily a bad reason as such. But in Greater Manchester in the northwest of England, we have some of the highest mortality rates for liver disease nationally. That might actually seem bad, but it's not necessarily, because the rest of the country is quickly catching up, and we're going to start to see the rest of that map turning a darker shade of purple over the next 20 years or so. In terms of the good reasons, I'm sure you're all aware, we've got a single hospital trust across Manchester, devolved health and social care. Manchester's got a very multi-ethnic community, which means that what we find here can be translated to other regions in the UK. And finally, we've got an integrated primary and secondary care system. So what is ID Liver? I think the main point about what ID Liver is that it's a multi-sector partnership. We wouldn't be able to do this with just academic organisations or NHS trusts. It includes academia, NHS, and importantly, industry partners as well, both large and small. And really, we're trying to bring together multiple diagnostics and data streams to try and see if we can prognosticate liver disease and work out who's going to progress. So, we were awarded Innovate UK funding back in 2020 as part of the Wave 2 of the Life Sciences Industrial Strategy Challenge Fund, and also another 2 million matched in kind funding from our global industrial partners, Roche Diagnostics and GE Healthcare. This slide, I'm just going to go quickly through it, but in the interest of time, but I'm happy to speak to people in the break. I can go into detail about each point. But really, I just wanted to show you this, just to show that the scale of the partnership, all the different partners that we've got involved, and what some of the key points are that we're trying to bring together as part of this consortium. So really, it all starts with the community liver assessments. We've set up clinics across Greater Manchester. And these, we've got an approach where we have reactive pathways, where we see people that you would usually be seen in secondary care anyway, and we're assessing them and recruiting them to the project. We're also proactively trying to find people with risk factors for liver disease. All the data from these liver assessment clinics is fed into, we're collating and we're feeding into a clinical decision platform that we're developing in partnership with Roche Diagnostics. And this is really a tool where we can allow clinicians to have all the data in one holistic dashboard and make the right decisions to manage the treatment for patients. Into this platform, we're feeding in algorithms that have been developed with our partner, AI partner, Jiva AI, and in partnership with the University of Nottingham. And this is really a risk prediction tool to see if we can work out who will progress to advanced disease, and can we streamline the pathways for liver disease. Into this platform, we're also feeding in novel biomarker data from the University of Manchester and exploring whether the addition of this novel biomarkers can actually help develop a diagnostic, and can it actually improve our prognostication abilities. With all of this, obviously we need a route to adoption, so we're working with Health Innovation Manchester, TrustTech amongst others, to kind of map that path to eventual and future commercialisation. And surrounding all of this is our work with patients and the public. And over the last 3 years, we've developed a network of over 100 members of the public and patients in our liver PPI network. And we're working closely with Vocal, who are based out of the Trust, and helping us make sure that everything we do is meaningful and not just developed in isolation of the people that ultimately it's going to serve. Like I said, quite a complicated slide, but I'm happy to talk afterwards. So how do we assess people? I mentioned we had our reactive and proactive pathways. So in terms of the proactive pathways, we worked with Northwest eHealth, one of our partners, to basically look through GP records across Manchester and find people with risk factors for liver disease, so obesity, diabetes, harmful alcohol levels, etc. We then invited patients for an assessment, and these assessments could take place anywhere really, but we try to be as close to patients as possible to make it convenient for them. So that acute hospitals, community hospitals, and indeed mobile clinics. And you can see a picture of a research van that we used in partnership with the Trust, where we went out across Manchester. And in the picture you can see we parked at Old Trafford, and that was really successful. The patients had the same assessment regardless of where we were parked. But I mean, you can see from the quotes from one of the patients that attended the van at Old Trafford, it's unsurprising that patients prefer this approach rather than travelling to secondary care. So Gareth mentioned this in his slide. Where should we go? Where do we go from here? Where should we cite future services? So Gareth mentioned we're working with Solis. And really what we're trying to do here is to access the linked primary and secondary care data sets to find out where in Greater Manchester is the problem. Where are the underserved areas that should be targeted? Where should we set up clinics in the future? So you can see on the right there's a heat map, an example that we've done with Solis, looking at the ID Liver cohort data. So that's over 1,200 patients, and it's looking at the prevalence of liver disease across Manchester. So obviously the darker is where we're finding more liver disease. So we want to really get that SDE level data to have what's the bigger picture, where are we missing, why are these patients ending up with liver disease, what, if we look back to the primary care records, are there any trends that we can find? That's what we're going to do next as part of the Diagnostics Accelerator with Health Innovation Manchester. I just wanted to show you this slide as well, what we've also been doing around looking at social deprivation and whether that correlates with clinically significant liver disease. On the left, you can see a heat map of the prevalence of liver disease, looking at the GP practices where we set up. And on the right, you can see deprivation, basically organised by ward. And the numbers 1 to 6 on this slide is the GP practices that we worked with, we piloted. And they're numbered in order of the increasing mean catchment deprivation score. And we did find a correlation between the deprivation and risk of fibrosis. I think this slide is really interesting. You can see the stark differences between deprivation and fibrosis in high deprived areas and lower deprived areas. In the high deprived areas, around 30% of patients had clinically significant liver disease. This compares to the lower deprived areas, the affluent areas, where we only found around 10% of patients. I think that data is really interesting because this is looking at the same risk factor. This is not, we saw no statistical difference in risk factors across the different wards where we went. But clearly, we're finding more liver disease in areas of higher deprivation. So that suggests that we should be targeting our efforts in these higher deprived areas, and we're hoping that the access to the SDE data and working with Health Innovation Manchester will give us that background about why this might be, and we can begin to explore that further. So following on from the success of ID Liver, the funding comes to an end in April next year. We've been awarded funding as part of the Advanced Diagnostics Accelerator, the program that Gareth mentioned, which is also funded by Innovate UK. We want to utilise some of the learnings that we found through the ID Liver program and really target these underserved areas using population level data. You can see the partners that we're working with at the bottom, which we're also worked with through the ID Liver project. And we want to explore how AI can really streamline the pathways as well. Of course, we'll continue to work in partnership with the patients and the members of the public as well. So to summarise, ID Liver is an academic-led multi-sector partnership. We can't do this in isolation. We're developing models, machine learning models for risk prediction of liver disease, who's going to end up getting advanced disease, who do we need to assess. And this is an iterative process, so we have that patient cohort of over 1,200 patients. We'll continue to build that through the next couple of years with the Advanced Diagnostics Accelerator, and we'll find more information about why certain people are ending up with liver disease, what can we do to actually streamline the pathways and ultimately develop innovations that are scalable and can be scaled not just in Greater Manchester to all practices is what we hope, but also nationally and beyond. And I'm just going to leave you with this slide just to say thank you. And I really like the quotes from one of the patients that we spoke to around their risk of liver disease. Thank you.
Thank you so much for that, Oliver. I really liked your slide. You said you're happy to discuss further with anyone afterwards. I think you really highlighted the complexity involved in getting to that position where you're in a position to scale. Yeah. And I think Tim Ferriss from NHS England, his parting message was around what's going to be adopted. It's stuff that can be scaled. So I think that scalability point in health tech is really, really important. And and I think it's important that you've demonstrated how complex that is, so people do appreciate that to get to that place is tricky, but you've got a plan, so
Yes,
I'm sure you'll get there.
Yeah.
Thank you.
Thanks.
I just wanted to say, so we've this morning up until now, so we're going to break in a second, we've really focused on health inequalities and how data, digital and technology can tackle some of that. After the break, we're going to move on to look at diversity, particularly in the